We're just a few minutes late, but I'm sure we will catch them up as we go forward. The next session is looking at research and design solutions for prosthetic problems and solving them for the now. This is a much more immediate technology that we're talking about. We have a series of presenters, and what I'd like to do is maybe just provide some framework. And I think the framework is important. Whenever engineers and clinicians get together, the first thing they have to do is they have to learn to speak the same language and understand one another. The second thing that they have to do is they have to find the right questions to ask and the right problems to solve. And something that is very important by bringing together people from different parts of the world with different experiences and with different backgrounds is that we start exploring what are the right questions to answer, what are the right problems to address. And so all the work that we'll be hearing about now is clinically led. It is led with the patient at the heart. It is led with determining and finding out and conducting research into what are the right questions, what are the right problems to address. And then approaching it with an appropriate clinical and technological approach, which might include orthopedic interventions for reconstruction and repair, limb realignment. It might include prosthetics. And I think we will hear about all of those in the next session. So what I'd like to do is invite our first speaker, Dr. Ian Radcliffe, to come to the fore. Ian is a senior teaching fellow in the Department of Bioengineering at Imperial College. His design portfolio includes developing disability and rehabilitation aids, and he's conducted extensive work on this over many years, including several for Paralympic athletes. Ian, we're delighted to have you present to us today, and over to you.
Thank you very much, and hopefully now you can see my screen. So today I'm going to be talking to you about user-centered design, and this is the design process that we've been actually using to develop some of the projects that Giovanni is going to be talking about later in the session. So I guess the first thing I need to begin with is to actually tell you or introduce to you the process of user-centered design. And this is the same kind of process that is used whether you're designing a mobile phone or a fridge or a ventilator for a hospital. Now, everybody will have a different variation of this process that you can see on the screen, but this is the way that I prefer to teach it. And the process, as I teach it, begins. It has five phases and begins with understanding the problem. And once we have an idea of the problem, we can generate some ideas based around it. Then we can kind of further develop the technology behind these initial ideas. We get into finalizing the design before we move into the final phase, which is the manufacturing realization of the product to get it into the marketplace. And I mean, as you see it there, it seems really straightforward, except it isn't. It isn't a linear line. There's no kind of A to B to Z. It's looping. It's continually involving iteration as you understand and test and evaluate and go back to the beginning. You know, the phrase "back to the drawing board" really stems from this level of development. So this is kind of shown in this image, as you can see, with the arrows showing the constant cycling, because you're constantly evolving and learning more as you go through it. So the thing that makes this user-centered is really this first stage. And this is where we investigate the needs and requirements of the user. And it's important because we need to better understand the problem that we're trying to solve. And this sets the foundations for the project, development that you're going to do, and to make sure that you can do it well. But there's also a kind of financial motivation to kind of getting this early stage right. And that simply comes from the cost of change. If you need to change your design early on in the development process, so if you need to change it when you're doing, you know, your concept generation or technical development, it's relatively low cost. If, on the other hand, you've built a load of prototypes and you've started tooling and you've developed a whole technology already, and then you have to go back and restart again, that's when it gets expensive. And we need to be mindful of cost, because at the moment we're talking about appropriate innovation and frugal technology. So keeping the cost down is important, not just at the endpoint, but also at the development process. So we have to consider that as we move through. So this slide is a variation on that design process. This is a very old design model known as the double diamond. Hopefully you can see why it's known as the double diamond. And in this, we put a lot more emphasis on this understanding of the problem. So here we have these 4 distinct phases: discovery, definition, development, and delivery. And like I say, we have the first phase that I spoke about earlier is really covered in these two starting points there, the discovery and definition. So we're going to go through each of these phases step by step. And I'm going to start with the discovery phase because that's the beginning. And I'm hoping that this is obvious to everybody here, and I'm sure it is. But other than the financial reasons, why is it important that we get this right? So I guess if we consider Maslow's comment from 1966, all you have is a hammer, everything looks like a nail. This kind of sums up nicely the point of my message today, that if you don't explore the problem at hand properly, if you don't investigate the issue, shown here very nicely by this screw, then the tools that you pick will not be appropriate for that solution. So the first thing you need to do is to investigate and understand the problem. And that way you can investigate suitable solutions that are appropriate to solve that. And what better way is there to understand the problem than to work with the people who are directly affected by it? So in the work we've been doing over the last few years, we've been working with partners in the field, speaking with P&O end users and frontline staff, and to better understand the problems that the users are facing on a day-to-day basis. And this is to better inform the design process. And we're also able to use this opportunity to discuss ideas that we've come up in this second phase, the kind of brainstorming phase, just to get an idea, early stage feedback as to what is going to be appropriate and what isn't. And I'd like at this point just to acknowledge there's some great work being done in the field by our associates at the University of Southampton, University of Salford, and the People Powered Prosthetics Group, who have been utilizing exactly these methods to create a map of the user's voice and explore the major needs from a user perspective. So in yesterday's session, it really came across clearly that there is a real need to have a joined up approach, a multidisciplinary approach that incorporates input from users, from surgeons, from prosthetists, from technicians, physiotherapists, to determine what is the best possible outcome for the user. So our investigations include not only P&O patients, but the healthcare professionals who make and fit the devices, who manage the rehabilitation process, and the community workers who support the delivery and care within the field. So further to this, we also need to appreciate that what is applicable in one country not necessarily stand true in another. So we've been working on projects in Cambodia and Sri Lanka, Myanmar, Tanzania, and now Rwanda. And we need to appreciate that the environment, socioeconomic situation, delivery models, and user perception will vary from location to location. We generally need to appreciate that there isn't a one-size-fits-all solution. That all of this information from the discovery phase is needed to kind of define the problem. And this helps us determine the user requirements. Now, these requirements are important as they're used to set out what our product must do, but they don't tell us what the product is. That's coming later. That's the design phase. Once we have the user requirements, we can then combine these with things like regulatory requirements to set out technical requirements. Now, these add specific values to the user requirements, and this information is used not only to set out what our design needs to be, but also provides us a target to evaluate our design against when we come back. And that's, again, what I was talking about, this iterative loop. We design, we create, then we evaluate against what we initially proposed in the first place. We also use the information from the field research to better understand the complete process of delivery of P&O services, and to understand how our project fits within that, within the patient's experiences, and explore any gaps that there might be in this delivery so we can better support this whole process. So, having understood the problem, we now start looking at some of the technical solutions that are currently in place, and some that have been used historically, some that are being used now, and some that are being used in different sectors that might be appropriate to our particular use scenarios. So we enter the development phase. And as you can see from the process chart, we're bringing in significant support from our delivery partners to help our research and development team create prototypes and trial new concepts. So in our case, we've been working very closely with the P&Os and the technicians at the Cambodian School of Prosthetics and Orthotics. And I'm pretty sure that Cicely is in the audience today. So I'll say hi, Cicely, and a big hello to the team out there who I know have been struggling with the flooding and the aftermath of the floods. The P&O team there and the technical team there have been instrumental in supporting these projects. And we've been combining the polypropylene molding techniques that they've been using with rapid prototyping tools such as 3D printing, so we can test and evaluate new concepts. And I mean, the team are amazing, and the wealth of experience that they bring to these projects are essential in order to make sure that the process is helping to develop appropriate solutions. So, having created maybe a number of solutions and evaluated them in our own labs and also in the labs of partners such as Blatchford's, who have kindly donated some of their facilities to allow us to test the devices that we create in a lab environment, we now again need to work with our delivery partners to formulate an appropriate manufacturing plan. And again, our contacts at CSPO have been fantastic in putting us in contact with local manufacturers so we can understand what is going to be achievable, what is going to be appropriate, and making sure that any solutions that we suggest are sustainable, that they can be produced and maintained locally. So, you know, when necessary, this may mean that we go back and redevelop and further iterate our design to adjust it and alter it and make sure it is appropriate for local manufacture. Now, once we reach the point that there is a functioning design that we can be manufactured, and we can work with our partners then to trial the system in the field and do kind of small scale clinical trials and develop a means that this concept can then be brought to the market. And you'd think that was the end of the project, but it's not, because the work goes beyond the simple delivery of a product, and we need to look at how this engagement, this network, can actually have a greater impact on the world at large in this sector. So we've been working closely with our partners to develop a kind of knowledge exchange, and I guess this conference today is a prime example of that. So we're talking of workshops and discussion groups. It's where we can investigate the latest practices and the new designs that are being developed. We can explore the current issues within the field, but also we can help train frontline staff with some of the research skills that we use day to day in our jobs, so that we're creating this new generation of prosthetists and orthotists who are kind of helping expand research within the area. And this work also includes engaging with members of the public, making sure that people are aware of the work that we do that's being done by our partners in the field, and kind of generating support for the programs in general. So you see, this isn't just about research in a lab, designers in a studio. This is a whole network of stakeholders who are involved in the process and delivery of P&O solutions, from funders and governments and suppliers and carers. But at the center of it, what we've got to remember is it's got to revolve around the user. And if we don't appreciate the user's perspective, then we won't be able to assist in producing an appropriate solution. Thank you very much.
Thank you, Ian. That was a fantastic presentation. And I'd like to remind all the attendees, if you post your questions in the chat, then we will be able to pull them together for our discussion at the end. But now I'd like to move on. And Mr. Godfrey Asimwe is from the University of Rwanda. He's a certified prosthetist, orthotist, and he works as a tutorial assistant in the P&O department at the College of Medicine and Health Sciences at the University of Rwanda. And he has supported the development of the P&O field in Rwanda through knowledge transfer and sharing of up-to-date technology that improves the well-being of the P&O service users. He's also a member of ISPO, the International Society of Prosthetics and Orthotics. Godfrey, we're very pleased that you're speaking, and over to you.
Thank you very much, moderator. Can you hear me?
We can, thank you.
Oh, welcome. I would like to first appreciate the University of Global Health and Imperial College London for this joint virtual conference, and all those that prepared this event to make it successful happen. So I'll be presenting now the requirements of prosthetic limbs in Rwanda, considering the economy, environment, and culture and lifestyle. Next. So one of the topics of this presentation, I'll be talking about the P&O services, like in general, the reimbursement procedure, the insurance and affordability, P&O and economy, of like how is it related, human resource, especially for P&O services, supply chain, I will talk about technology and the culture and political will of government of Rwanda, as well as data management. Next, please. So the history of P&O sector in Rwanda, especially delivering prosthesis, takes us back in 1980s. But most of the facilities were established in 1995. That's after the genocide against Tutsi, and it goes until 2001. This was established by different NGOs, especially Humanity and Inclusion, which was Handicap International by then. So most of the staff were trained by Tanzania Training College of Orthopedic Technologists, but some of them were also trained in Lome, Togo in the mid of 2008 and 2011. So let alone Rwanda thought about it and started the School of Prosthetists, and although this program is being learned in the College of Medicine and Health Sciences, which started in 2011. It has graduated 53 graduates so far, and half of them are employed, most of them in government institutions, private institutions, as well as some NGOs. Another thing is that prosthetic services in Rwanda is being counted as part of physical rehabilitation services. So it's one of the things we have also to talk about. Next, please. So in Rwanda, I just wanted to show you the geographical locations of the centers of prosthetic and orthotic services. They are only just those that are active, the active services. So there is one in north, another one is just, you can see on the western part. There is two in south, and others two in eastern province, and most of other are located in the city of Kigali. So can you go next slide, please? So as you have seen, most of the most of the centers are being established in Kigali. So if you see how Rwanda is today, if you get the biggest province is Eastern. So the biggest province in Rwanda, when you see Eastern province, it has only 2 centers, which is hard for the service users to find where to go. So you find like service users are taking long distance, spending nights, spending their money, leaving their families, going for seeking a service in a far place. So the requirement here is that the government of Rwanda should think how to decentralize these services, especially in most of the district hospitals, so that communities around there, especially those need these services, will access them without getting difficulties. Next, please. So now let's talk about insurance strategy. Most of the Rwandan citizens use community-based health insurance. But unfortunately, when it comes to prosthetic services, it only accounts for some in some hospitals. Like you find into only teaching hospitals in Rwanda, it's where this community health-based insurance is being used to offer services to those who need prosthetics and orthotic services. You ask yourself, why not other services? So the claim here, according to my experience, people say that these services are very expensive, but they don't account for how long is going to help this person who's going to be given such a service. If I'm an amputee, I need this service, I'm going to get a prosthesis and use it for at least between 5 to 6 years. So this will contribute much to my life compared to what the insurance has paid to me. So another insurance is this one for most of the government workers, civil servants. It's for RSSB. So it's also it covers 90%. It covers 85% of the service, and the service user pays 15%. Another insurance is for military medical insurance. All the military casualties who get amputated due to military events or other diseases like non-communicable disease, but their families or them, they are being covered by this insurance, which is under military scheme. Next, please. So if you see how insurance is acting in Rwanda, so there's one research that was conducted by one of our colleagues, and was asking the affordability, generally was asking about the P&O service delivered in Rwanda, but he tackled also the affordability of P&O services. So most of the people, like 80%, responded that these services are very expensive. They are not affordable. And the reason being very expensive, and others were saying they are not covered by insurance. Can you go next, please? So according to Rwanda tarification of P&O services, you find that the transtibial prosthesis is ranging between $285 to $653, depending on the materials making that prosthesis. So if you see the economy of the citizens of Rwanda, few people will afford this kind of prosthesis. But some of them are being maybe helped by NGOs or helped by, if you are poor in a certain category, categorized by the government of Rwanda, so you can go to certain hospitals and get this service for free of charge. But another thing is how this information is getting to the citizens. So does this sector contribute to Rwandan economy? I can say that this sector contributes to Rwandan economy on a high percentage. If I'm a service user of P&O services, I get a prosthesis. I am no longer depending on other people. I depend on myself. I can go out there in the community, work for myself, help my family, or continue the job I was doing. But if I don't get this service, I'll be just staying at home, complaining about life and other things. So it will be very hard for this person and the family, and this person will be a burden to the country. Another thing we have to do is getting health economics, like we have to do some cost calculations to make it on a standard level. In Rwanda, even though there is this tarification, it's not 100% because we find patients are complaining, even the service givers, those are giving these services, are complaining that the materials are very expensive, but the tariffs are not changing. So we need to do some cost calculations. The government should act through different institutions to come up with a satisfying tariff or a satisfying strategy to make these services affordable. Next, please. So in Rwanda, there is 67 professionals working who graduated or who are professionals in this sector. 5 of them, they are certified prosthetists, orthotists. Most of them are working with the university, and other 62 are associate prosthetists, orthotists as designed by ISPO. And when you see, according to P&O standards designed by WHO, on the page 57, it states that a country, like an average country, should require 5 to 10 people, clinicians. These 5 to 10 P&O clinicians, these are like, those are who are working with the patients. And this should be accounted for 1 million of people. And they should be also assigned with some technicians. But in Rwanda, this is different. Some technicians in Rwanda are not being recognized because they say they are not allowed to be in the hospital setting, or if they are there, they are being paid on a private basis. They are paid by those especially private clinics. So this is also a requirement where these technicians are helping a lot. They are helping these clinicians to accomplish the goals. If I'm a clinician, I'm just focusing on patients. But if I also required to do this technical work, I will spend time doing this technical work. I will not serve the patients effectively. So another thing is limited of infrastructure. We still need to build P&O services, improve those that are existing in Rwanda. And if we do this, we will improve the quality of services being delivered. Next, please. So in Rwanda, P&O materials, some of the materials are not considered as medical consumables or equipments. Some of them, they just think they are materials used in like engineering field, but we are struggling, or we are working hard to convince those that are in charge to consider these materials as part of medical and consumable equipment. So another thing is having professionals on board to avoid different fraud and poor supply of these products. Sometimes you find if I need to order something, I haven't included a professional who even knows the specifications of this particular thing. At the end of the day, they bring you a component that is not of the quality you wanted. So professionals, I'm calling for the government to include the professionals and other people involved in this field to get good quality of products and materials. Next, please. So talking about involvement of professionals, the colleague who did research also said that most of the professionals say they are not involved in the planning of the prosthetic sector in Rwanda. Only 4 of them, for those who asked, 4% of them said yes, but 96 of them said we are not involved. Next. So the reasons, he asked 2 reasons. One, the most reason, which accounts for 96%, the professionals said no coordination unit in the Ministry of Health or at the national level. So there are like no coordination department at the Ministry of Health or at the national level that connects the professionals with the government. And some of them accepted that some of professionals are not known. Like, because this profession is new in Rwanda, when you go to the Ministry of Health and you say, do you know about prosthetics and orthotics? Some of the high offices people, we tell you that we haven't heard about that. So we need also to create an advocacy for this profession so that people know about prosthetics and orthotics services. Next, please. So let me talk about also the technology used in Rwanda. As Martin did research, he saw that in different centers, they use conventional technology, which is the ancient one, but some of them are trying to come up with contemporary technology, which is the current. But when I say the current, is just like lamination sockets and using this modular different components. So some of these materials, they are being bought privately in private companies, and others are coming from abroad. So there is no like manufacturing companies in Rwanda which make P&O services, P&O materials, sorry. But most of them are being shipped from abroad or bought on a private basis, which creates a high cost of the P&O services and sometimes leading to delays in service delivery. Another thing, talking about this technology, as we saw, Rwanda is a hilly country with a lot of mountains. We need materials, especially the foot, the shanks, and those that are making sockets, which are durable, so that it can help people living in this environment. If you prescribe something that is going to break tomorrow, you are not helping a patient. You are not helping this service user. So we are calling for the research, especially in the field of prosthetics, to come up with specific materials that are being used in this particular environment. Not just accounting that Rwanda is among the developing countries. Let's send these components, they are working in developing countries. Next, please. So Rwanda has made some advances in technology. We have received so far some of the 3D printing machines from different institutions. Like one is in Southern Province, HVP Gatagara Nyanza, on the help of some donors. Another one is technology of laminated sockets. We are now shifting from the ancient thermoplastics to laminated sockets. So we are working together with different institutions to see how the 3D technology can help patients, and also these laminated sockets can be incorporated in daily works of our professionals. Next, please. So in Rwandan culture, it was like hard to see someone wearing a prosthesis. If you prescribe a prosthesis, the patient will say, I want it covered, final finished, and try to make it as similar as my leg. If you see on this particular photo, this lady is proud of having the shank just as it is. But if you go in the community, in some communities in Rwanda, people will say this person is wearing a robotic leg, like you are like a robot. So they see you different, and they start like discussing about you. And some people don't find it comfortable when they go out there. So the culture should also be taught about these services, especially when you go to communities. People should know that if I lose a leg, I can get another one, an artificial limb, and enjoy life and continue as it is. So people should know that prosthetic services are among, like, they put them in their life. So they should not discriminate or find these people as people who doesn't exist in a particular world. Next, please. So the government of Rwanda has worked to strengthen some of the things that I was talking previously. First one, they established a regional center of excellence in biomedical engineering. This, like, it will bring together interprofessional collaboration between engineers and rehab professionals. So it has so far provided some scholarships in biomedical engineering, in rehabilitation, especially in prosthetics and orthotics, and this is a commitment by the government. So the government of Rwanda has signed different international MOUs with different NGOs, especially working in P&O sector. Especially one is ICRC, Physical Rehabilitation Program, which is now working to establish National Physical Rehabilitation Task Force and other related things. Another one is Rilian Fund, which is working to develop the quality of services, especially P&O services in Rwanda. It has supported the University of Rwanda in equipping the campus orthopedic laboratory that is being built in the University of Rwanda, College of Medicine and Health Sciences, and also ICRC has participated in refurbishing and establishment of such a facility in the University of Rwanda. Can you go next, please? So as this session is talking about research, I cannot go without telling the audience or the people around the world that we need to improve the way we are collecting data or the way we are doing research in prosthetics and orthotics. In Rwanda particular, the data are missing. You cannot find most of the data in prosthetics or the data of amputees. They are not there. So if we have data, we can improve the advocacy and drive investments in this in prosthetic services. So this data, we can use them to motivate government to mobilize resources for prosthetics and orthotic services. And with this data, we can improve the livelihood through talking to insurance companies, telling them how this service has improved the life of the people. If you have done a research on quality of life of P&O services, you can present it to different institutions, especially reimbursement institutions, to show them how this service is helping people around there. So there are some records being done in Rwanda, like if you do patient assessment, you record different informations, but this information, where are they being reported? Is there any like tool in the Ministry of Health at the national level that collects all the data that is being given by hospitals? Or we just collect the data and keep them in the files, hospitals, and we end up making the hospital office or the P&O service very full with files without the use. So we should find the way of reporting data from different levels of institutions in Rwanda. Next. Okay, I think this is the end of my presentation. Thank you very much for listening to me.
Thank you, Mr. Godfrey. That was a fantastic presentation and gave us a real perspective on services in Rwanda, and it was very open and honest about some of the issues that you face as well. I hope we have time at the end to discuss these points, but what I would like to do now is move on quickly to the next presenter, who is a postdoctoral research associate at Imperial College, Giovanni Melandri. His work focuses on product development and applied research in orthopedics and rehabilitation, and that includes prosthetics, surgical tools, and assistive devices for rehabilitation. So Giovanni, over to you. Thank you very much.
Thank you. I'm going to just share the screen. If that's allowed, I think that's good. Is that looking
we can hear you and we can see your slides.
Let me maximize it. Is that all good? Yeah.
Yeah.
Okay. I just wanted to thank the organizers of this conference, especially. It's wonderful for me to hear to have more engagement with what is going on in Rwanda, and to understand better how the relationship is growing between our institutions. And so I'd love to show you some examples and ideas about design. There are other projects which I can't talk about today, but I'd like to just show you one example. All right. So the other day, Dave Henson, one of the organizers, was explaining to me about this idea of the sweet spot between education, clinical policy, and technology. And obviously, as people trying to work in the sector, we're trying to find that balance, basically the sweet spot in the center, which overlaps between the groups. but I would like to talk a little bit more about the technology aspect, because I think it's often misunderstood. Often we feel like there's a challenge, there's a gap basically between the different parties, and there's this gap in the middle that we're trying to fill. So I'd like to just give a perspective from the technology side to help to understand that. So we've also seen an image which is similar to this in other speakers yesterday, and we have the different clinical services which we would like to bring in an interdisciplinary way to support the patient in the best way possible for the most effective outcome. So we can imagine all the different groups, and this is already a good thing. This is a great thing to be advocating for. But if I've drawn the circle there, and it helps to sometimes think what is outside of that circle. And what is outside of that circle is the product designers, the manufacturers, the salespeople, and also important are the buyers who are buying those materials into the country, who are negotiating supply agreements and creating sustainable pathways for products to get in. Otherwise, the clinicians can't do their work. So this is an important aspect to this. We in engineering domain have got this classic understanding of concurrent engineering. Originally, someone on the left at the top would think of an idea for a new product. They would throw that over the wall to the next person who would think of how to build it, and eventually it would go over the wall all the way to the manufacturing. So this idea is similar to the previous idea, basically saying that in the bottom image, you can think about a group of those same people coming around the same table and breaking down the walls and discussing what are the best needs. This is a very difficult process because, like Professor Bull was saying, that they often speak a different language. They are having different experiences. And so there's a huge need for, and especially if it's across cultures and geographies and time zones, a huge need for team collaboration in order to come to a good solution. So if we think about prosthetic technology, we often have a misunderstanding about what is technology. We see technologies such as these, which are very, very high tech, but they tend to be in a research space and basically are not able to be reach the general amputee let's say within the next years. They are far away from the market, and they're more of an experimental setting. In contrast, there are some robotic technologies which are more appropriate. This is a project that I worked on previously, which is, let's say, a hybrid type of approach, but it's still robotics. It's still expensive. And so I learned from that experience in Italy here that their view of a low-cost device was 10,000 euros, which obviously to us in a more global setting, that is just unaffordable. So even for them, low cost was not low cost enough. So I proposed, and you can see here, they win a lot of awards and there's a lot of media attention, but I would contend that it's not a sustainable way to go forward. So very interesting, but I would like to draw attention to the polypropylene technology, which is often overlooked because it's so simple in one sense. But one of the most widely used prosthetic technologies that was introduced by the ICOC, it's low tech, but it's got an enormous impact on patients' lives. And it forces us to rethink what we think of when we think of design. Excuse me. Okay. So moving forward, the question for the designer, is the design actually serving the patients? Where are the gaps and what's going on with regards to our decisions that we make in our designs? Is the technology neutral? Basically, are we trying to get to the maximum technology possible? Or are there various forces, market forces by different companies who want to deploy their product? And this also ties up to the establishment of prosthetic workshops, because those are very expensive. Obviously, there's often a link between the workshop and the technology. So the design responds to the needs of the user, but as Ian was saying earlier, this is interpreted by the designer. So you need to understand the needs. If we look only at cost, we often forget that the product drives many costs, but many of these costs are hidden and only will be discovered later. So we need to be very transparent about the way we work. The same with lock-in. If you buy one product, you might be forced to buy another product. That can also be very, very difficult. And then what is good value for money? So the design philosophy that I've laid out here is understands that small design changes can have large effects on the patient's life. Compatibility with what works already, something that is more flexible and not over the wall as I described. And taking important focus on the design for manufacture, assembling, and servicing. The other barriers which we all know about are transporting of the products, taxes and fees, time and customs, etc. But I can't get into that right now. Just as an example of how technology can be viewed, this is a cybathlon, which is a competition showing the ability of assistive technologies. Now, this is based in Switzerland, and this year in 2020, it was held online because of the pandemic. You might think that these technologies are all out of reach of the average user around the world. These are just the cutting edge of technology. But it's something interesting that we noticed. I would encourage everyone to go on YouTube or on the Cybathlon website and watch these inspiring videos to see them competing in everyday life tasks. What we saw from this, which is fascinating, here's one of the examples. This man is wearing a robotic leg, which probably would have cost tens of thousands of euros. So it's a research device, very expensive. And he's performing a very difficult task, carrying apples, walking through boxes. In contrast, here we have a 4-bar linkage leg. You can see the patient is using it very differently, but this has got no electronics and no control system. And it's also a Swiss group, but it's a 4-bar linkage, as many of us know, these polycentric technologies. And what was interesting about this was that who was the winner? This 4-bar linkage was actually the winner of the race and beat many of the other electronic technologies. So it shows you the limitation that high cost and high technology does not automatically imply high function. So obviously these are very highly trained individuals, but it just shows you the potential. And it was interesting to see that even in the hand race, the mechanical hand beat many electronic hands. So I would say to patients also not always to aspire to the highest technology, because it can actually impair the function of the patient. It's an interesting perspective to be discussed. Also, I would like to play a small game of guess the product. Thinking about a product, it's globally available. It has a safety critical design. It can be aligned and adjusted to different user needs. If it's badly aligned, it is uncomfortable and tiring to use. The parts and the servicing are available everywhere. What is this product? You might have thought, but the answer is the bicycle. As we heard from our speaker yesterday, from Giles Dooley, he was saying he wants his prosthesis to be serviced at a bicycle repair shop, and we've been very inspired by this. So function and mobility are key, and basically that the user can actually adapt the product, as you see on the bottom left. I think this is a Rwandan project for extending the ability of the bicycle to carry more load. So in the same way, we must suit the product to the needs of the patient. And I hear about the heels and I'm working on the ideas for heels in Rwanda at this point. So also looking at fit for purpose, this is also, you could be seen as a type of bicycle, but obviously very simple. Does it fit the user needs? Well, if it's a child, yes, but as the child grows, they may have different needs. So can the user adjust it? Here, the seat can go up and down. At the extreme, you could think of a bicycle which has many adjustments, but costs more. So you can start to see that adjustment and who adjusts the product is a very important factor. The other thing is safety. We know a lot about safety with regards to transport, with regards to checking that a product is still fit for use. With regards to tires, as you see on the right, this tire is getting worn, and you can imagine that when a tire gets bald, there's a little indicator which shows you that this device needs to be replaced, that it's getting dangerous. And the same with the wear indicators on the bicycle brakes on the left. So we can design products which can assist the users and empower them to know what is happening with their device. So with this, I'd like to talk a little bit about one of our projects following on also with our team in Imperial College. We, as has been outlined by Ian earlier, there's a lot of research going on to the user's social, cultural, and environmental conditions and their needs. This is images from the east, but you can see control and stability, range of motion, water and mud resistance are all critical factors. So if we convert those into user needs, I'm not going to go through all of these in detail, but you can see on the right, this is the WHO standards for P&O, and I would encourage all of you to read them if possible, because they're very enlightening about the actual important factors for global prosthetics. The one factor which I thought was very interesting, someone commented that the cosmetic appearance of the device, and the previous speaker has just mentioned that with regards to the color of the feet and looking like a robot, can actually have an impact on the patient's mental health. If the person feels different, if their skin doesn't look natural, then maybe they will feel depressed. So, and also their social integration can be affected. So I push very strongly for a very beautiful looking prosthesis that is adaptable to the cosmetic needs of the patient as well. So we've been working on a limb kit prosthetic knee, which is a best-in-class polycentric knee for adult and pediatric needs. We're also looking at the development of socket technologies, which would be more towards direct casting, basically to save time and to save costs in setting up of facilities. And we're also working on sports foot. Looking at the best-in-class functionality, we were inspired also by the Jaipur knee, which is a very successful knee in India for low-cost delivery. And we developed, you can see the device on the top right, the stability of the device is very good. The range of motion of the device is very good, and it is compatible with above knee and through knee amputees with a very small profile, so very low profile, as you can see in the trouser leg in the center. We've started testing it with water and mud to try and understand what is the impact of environment on the product. And we've designed compatibility with the ICRC system as on the left-hand side. Here's a little bit more what I would call field testing at a soccer field. And you can see the very good function of the knee in terms of high range of motion and good kneeling functionality. Here's a few more testings. This on the right is an ISO 10328 overload test, which takes it up to, and we've recently passed a 400 kilogram load, which is showing that the device is very robust. And we are busy at the moment with fatigue testing, which simulates 3 million steps. Looking at materials, the materials must be empowering and sustainable, guided by the Sustainable Development Goals. We're inspired by the car and the bicycle industry, but also the P&O industry, which has got a wealth of knowledge about what is appropriate for different environments. Looking at different manufacturing methods, I can't spend too much time on this, but there are many different ways to make products, and they have a very high impact on how the product looks. Like this iPod here is actually an extrusion. Many people wouldn't know it, but that was one of the ways that they managed to mass produce it for reasonable, basically to get it to many people. The same with the car bumpers. It can be a vacuum formed device. So we're trying to explore different ways to manufacture. Speaking about injection molding, which is what many people want to know about, it's cheap and quick to produce complex parts, but there's a secondary effect. The molds are very expensive and they start to dominate the design process. So if your volume, if you don't sell as many as you want, you pay extra. If your design needs to change, you pay extra. If you need alternative sizes, you pay extra. So it's a very good technology, but it needs to be used with care. And I just wanted to close off there and thank all the partnerships that we have. We're growing this initiative, and we'd actually be very interested in regional manufacturing in Africa. And I know some other, another speaker yesterday, Michael Stevens from Jumping Kids mentioned we should have an African brand of prosthetics. But I also support the idea of regional manufacturing in Africa. So I thank you very much for listening, and I welcome questions.
Thank you very much, Giovanni. We will have just time, maybe just for one or two questions very briefly for everyone. So I wonder if the three speakers could make sure they turn their cameras on and be ready to answer the questions. I think I have a question for Mr. Godfrey, which is, we have many graduates in prosthetics and orthotics, and yet only half of these are in employment. And I guess my question is why. You answered it in part, but also secondarily, is there are the professionals regulated in the country and licensed, and is there a structure for that? I wonder if you could just let us know briefly.
Okay, thank you. Let me tell you that our profession is regulated by Rwanda Allied Health Professions Council. So if you graduate from the university, you have to pass a licensing exam to be allowed to work in hospital setting or to practice. So
and then my second question is really about the employment.
Yes, the employability is still a problem. That's what we are advocating for. This is because it's not like the jobs are there, but the way of getting jobs is a problem. this is because some of the directors of hospital, they don't take P&O services as a priority. They prioritize for other health services, but if you come to P&O services, it's not a priority to them. It's not a priority to the Ministry of Health. So we need to advocate for this to meet with WHO standards. And there are some laws being developed by the Ministry of Health in Rwanda. Like there is a law putting on all the health, like all the P&O services on district hospitals in Rwanda. That law were not even implemented. It was established in 2016, but it wasn't implemented until like last few months, when the government said that we should put these people, especially the P&O professionals, on the structure. Before, we are not on the structure. We are licensed, but we are not on the structure of those who are supposed to get a government salary as a government workers. So now, because of Rwanda Society of P&O has advocated, kept on pushing, talking to different individuals in the ministry to tell them that these people are worried about their future. We are training people in the university, but they are not assured of what they are going to do. And the gap of job opportunity is there. Why can't you put them on the structure so that these hospital managers can find a way of hiring them? So far, I think it's in a good way. The next thing is to do the follow-up. If this being on a structure is one thing, and hiring people, employing people is another issue. So we keep advocating for that. I know Rwanda Society of P&O is not sleeping. We keep on pushing until we get the final stages of employing our colleagues. Thank you.
That's wonderful, and thank you. And it seems like there is really good leadership there, and that's evident that comes out from this. Yeah. I wonder if I may move on to a question for Ian. So Ian Radcliffe, one of the questions that's come out, and I think is relevant across the world, is whether or not smartphone technology can be incorporated in our design concepts as we move ahead because of their ubiquity.
Yes, so I know that our colleagues in Southampton have been doing a lot with data and information shared through smartphone technology. I think there is some caution though, because although there's plenty of stats around saying that there is like 4 smartphones to every living human being around at the moment, but it's the question of how they're being used and the appropriateness of them. So I know, I'm sure it was when we were in Cambodia, we saw that lots of people did have smartphones, but people were still writing their phone numbers on the wall where they kept their phone. So it's the use and understanding and the application of the technology and making sure that it is appropriate. So the user interface aspects of it and then the educational aspects of it need to be brought up with it. But definitely with regards to storing and transferring data, I think there's a lot of potential there.
Thank you, Ian. And maybe a final question, which I'll direct to Giovanni. So Giovanni Melandri, there is a history, and I think Saeed Saidi was proposing this in the questions, of establishing mobile prosthetics workshop fittings, sort of in vehicles and the like, and to have satellite services being led from core services, but then having satellites. And is this something that could be incorporated into the way we design and manufacture prostheses? The idea of using mobile services.
Yes, I mean, if you've seen there is such a thing as a mobile bicycle workshop. We have those. That is a concept which you see in different places in the world. But one of the challenges is that, especially the sockets, the physical size of the socket requires especially if you cut a socket or you heat a socket, or a lot of those processes are noisy. Make a lot of dirt, or basically create they basically are somehow more, let's say, more industrial type of processes. So you would have to think very carefully about exactly how so you would have to say, what is the scope of my mobile clinic, and what are the processes that I can fit inside there? You might have to buy a very big vehicle. we've done one project in South Africa similar to that, where we did it with the nurses to design a vehicle specifically for them. But once you have that, then you would have to work backwards to the product, actually, which is a completely inverse method of getting to a product. It is possible. I would encourage people to think that way, but the barriers are not small. So if people would like to set up that, I think there would be a lot of opportunity between, say, us in Imperial College and someone in Rwanda that wanted to set up a facility over time to explore that. Yes.
Thank you. I think what we'll do for in the interest of time is we will finish this session. I want to thank the three speakers, Ian Radcliffe, Godfrey Asimwe, and Giovanni Melandri, for their great presentations, demonstrating not only the importance of their work, but also the collaborative nature of it, the strength of engagement that is required, and making sure that everything that we do is very driven by and appropriate to the environment and the requirements of the locality. So thank you all very much. And I think what I'd like to do now is hand over to Claudine Humeret, who will chair the final session. Claudine, over to you.
Thank you, Professor Bo. And thank you to all the speakers whom we've learned so much from in the past 2 hours. We cannot conclude this conference without bringing up what I think is the key driver of most good things actually in our society, which is education. Our speakers in this session have all witnessed the power of education in driving change in healthcare. I would like to first welcome Dr. Jean Kagwiza, the principal of the College of Medicine and Health Sciences at the University of Rwanda. Dr. Kagwiza holds a PhD in holistic rehabilitation that uses biopsychosocial models and the International Classification of Functioning, Disability, and Health as a need to improve comprehensive healthcare for people living with HIV and associated disabilities. She has been at the University of Rwanda since 2000, where she is involved in teaching, research, community engagement, and has even initiated a community-based rehabilitation project. Please welcome Dr. Jean Kagwiza.
Thank you very much, Claudine. Thank you very much to the University of Global Health Equity and Imperial College London for giving me the opportunity to speak today. I'm very happy to share with you the experience of the University of Rwanda College of Medicine and Health Sciences experience in educating clinical professions in relation to amputation, rehabilitation with prosthetic. Next slide, please. The University of Rwanda was established by the government of Rwanda in 2013. It resulted from the merger of 7 public higher learning institutions which existed before. The example of Rwanda, known as NUR, the example of Kigali Health Institute, known as KCHI, and others. Next, please. Next, please. Thank you. The University of Rwanda is composed by 6 colleges. The College of Medicine and Health Sciences, known as CMHS, our college, the College of Arts and Social Sciences, the College of Agriculture, Animal Sciences and Veterinary Medicine, the College of Business and Economics, the College of Education, and the College of Science and Technology. Next, please. Next, please. The College of Medicine and Health Sciences training focuses on very important specialties. And one of the specialty is clinic, which have very important programs, the example of medicine, pharmacy, nursing and midwifery, anesthesia and others, diagnostic specialty with biomedical laboratory sciences and medical imaging science, community health specialty with public health, environmental health sciences, nutrition and dietetics and others, rehabilitation specialty. Here we are today with prosthetics and orthotics, physiotherapy, occupational therapy, ophthalmology, and clinical psychology. The management of amputation would need majority of cadres trained in those programs. But more importantly, the emphasis should be put on interdisciplinary teamwork. The College of Medicine and Health Sciences focuses on these programs to address the quality of care in the continuum of care for a well-organized and holistic health system. Next, please. Next, please. The training in prosthetic rehabilitation started being discussed in 2007 during a congress organized by the African Federation for Rehabilitation Professions, which took place in Kigali, and which came up with a very important recommendation to create a school of prosthetics and orthotics in Rwanda. Then in 2011, the Department of Prosthetics and Orthotics was created with an orthopedic technology program for 3 years, and with an award of advanced diploma in orthopedic technology, category 2 as classified by ISPO. In 2014, we managed to get the ISPO accreditation, and we managed to maintain it until now, despite the difficult conditions, like lack of our own lab, but we had an alternative of using the University Teaching Hospital laboratory, and insufficient number of local trainers. We have the opportunity to hire from outside Rwanda experts who come and help us in training, insufficient resources such as books, lab materials, and consumables. But I'm very happy to say that we have managed to train 53 associate prosthetists and orthotists in Rwanda. Next, please. Next, please. Also, I'm very happy to say that we now have our orthopedic laboratory to train our students, and that will allow us to even attract international students. We are so grateful to the ICRC and Lillian Foundation for the huge support in coming up with this orthopedic laboratory, but also Ottobock, which assisted us to come up with a good design. Our students and our lecturers are involved in community service. We always organize a community-based rehabilitation disability week together with the other programs such as physiotherapy and occupational therapy. And we have good partners. We sometimes plan with them to go to the community. We have in-country partners, the example of the National Commission for Persons with Disability, National Union for Disability Organizations in Rwanda, and our professional organizations, FATO, ISPO, ICRC, Lillian Foundation, the Humanity and Inclusion, Universal Strathclyde, Ottobock. Next, please. Next, please. Despite the challenges we have, the gaps we have in our education system, the achievement is bigger than the deficit. We have trained technicians, as I said before. We have workshops in our country, not sufficient, but at least we can say we have the basic to respond to the amputee needs in our country. We have strategies in the University of Rwanda to improve the quality of education and prosthetic rehabilitation. Next, please. Next, please. Next, please. Next, please.
Sorry,
Next.
guys, we are having technical difficulties, but we should be
It's
moving
fine.
forward soon. Apologies.
It's okay.
Thanks a lot for what you have shared so far. I'm learning so much about how things are working in Rwanda and at the University of Rwanda. I can't wait to hear what you have to say next. I think we are ready to move on.
Can I go on, please?
Yeah, thank you.
So I was just saying we have good strategies to improve the quality of education and the prosthetic services in Rwanda. And still I'm sharing the experience of the University of Rwanda. So we have a center of excellence for biomedical engineering, e-health and rehabilitation that supports advancing training for our university. So currently we are developing a program, a master program in rehabilitation science, and we are going to upgrade the prosthetics and orthotic program to bachelor degree. So we are organizing also professional short courses, which are really advanced, and graduates from the advanced training should be able to develop long-lasting and lightweight prosthetics and orthotics and mobility aids. They should be able to develop and promote multidisciplinary patient care approaches and interventions for persons with disability among rehabilitation and mobility staff. They should be able to offer gait analysis services and collaborate in computer-assisted manufacturing of rehabilitation devices. Next, please. The center has partnered with CrossFit to produce digital sockets for the prosthetics for almost 5 people with amputation in Rwanda. The project will be done in phases. We are still at phase 0, which is going to start very soon. And the other phases will follow. And we are inviting more partners so that we can increase or improve the capacity, because it's still not at a good, I mean, the way we would like it to be at a good level. Next, please. Now, as I said, we still have shortfalls. We would like to have more programs in rehabilitation, because we believe within rehabilitation first, then with other professions. So we have developed a curriculum on speech therapy and audiology, but we have not implemented it. We look at it as a shortfall. We have, as I said, we are going to develop, we are developing, sorry, a bachelor degree program in prosthetics and orthotics, but it has to be improved. It has to be approved first in different organs, then it's going to be implemented maybe next year. We are aiming to reinforce the interdisciplinary teamwork from the pre-service. So among the medical students and the rehabilitation students and the community health students, so that from the pre-service, they develop the culture, they understand the importance of interdisciplinary teamwork before they go out there and start using it in their job. So the Center of Excellence for Biomedical Engineering, e-health and rehabilitation is being developed, and we are going to construct the center at Kigali Economic Zone, equipped, very well equipped, with a more advanced prosthetics and orthopedic laboratory. The program of rehabilitation, the Master in Rehabilitation, is going to be offered jointly between the center and the school where the prosthetics and orthotics is hosted, and other rehabilitation programs. We have our staff who are pursuing masters in UK at the University of Dundee. We also have those who are pursuing a bachelor degree in Thailand. Some have graduated already, they are back in the country, and others are going to graduate next year. So we are hoping to have staff, Rwandans, and maybe decrease hiring experts. Of course, we'll continue so that we look at mentoring, because when they come back, maybe they don't have yet enough experience in teaching. So the experts will continue and teaming with them and mentor them so that they are skilled in teaching. Next, please. Yes, we do community engagement, but I think we need to continue maybe develop more projects and maybe invite partners and work together so that we can reinforce the community service. And maybe use the mobile clinic. As I said, the digital production, we are aiming to go to the community and use mobile clinic. Research, the college is really experienced in research. I can say it's a leading college for research for the University of Rwanda, but we have not done much in the research of in the area of prosthetics and orthotics. So we are putting more efforts with the center to improve our research in that area. Next, please. So last but not least, I'd like to say that wherever you are, in whatever profession you belong, please let us put hands together and improve the quality of care and quality of life of amputee clients. and improve the service of prosthetics globally. Thank you very much again for the opportunity.
Thank you, Dr. Jean Kagweza. It's so nice to see what Rwanda is doing in the educational services and how they are planning to improve for the future. Now I'll call on our next speaker, who is Dr. Onela Masimbi. Dr. Onela is actually a colleague of mine at the University of Global Health Equity, and she's also a friend. She holds a Master of Science degree in Global Health Delivery from the University of Global Health Equity, where she now works as a lecturer in basic medical sciences and as a coordinator of the Simulation Center. Dr. Masimbi obtained her bachelor's degree in medicine and surgery from the University of Rwanda. Please welcome Dr. Onela Masimbi.
Thank you, dear Claudine, for the nice introduction. Thank you, UGHE. Thank you, Imperial London College, for giving me the opportunity to talk about the amputee journey. This is a great honor for me, and I hope this will be a fruitful discussion that will help us healthcare providers improve the way we provide care to the amputees. Next slide, please. So this is the overview of my presentation. Next. So, what is our priority as healthcare providers, as policymakers, as leaders? So worldwide, especially in developing countries, people who underwent amputation are sometimes left alone to manage their lives with little help, sometimes with no help at all. So we are called, it's our goal to promote their health and wellness by providing them an equitable access to all health services that they need, and by providing an equitable access to opportunity in the community. Here I'm mentioning about referring to opportunity to work, opportunity to education, but also empowering them by take care of their lives, by engaging in healthy lifestyles. Next, please. So how is this going to be possible? This will be possible through, as my colleague and other speakers have mentioned, everything will be possible through an interdisciplinary collaboration between all the people involved in the care of someone who underwent amputation. The Agency for Clinical Innovation developed this nice framework. It's the minimum standards of care. It shows us how we should provide the comprehensive care since before the amputation surgery and throughout the all stages of healthcare of someone who is going to be amputated. First of all, the care should be coordinated across multiple disciplines. The surgeon who are going to operate that patient should be involved, the medical doctors, the rehabilitation team, and especially the patient. The patient should be involved. By comprehensive care, it means that we are going to involve the patient. The patient will take care in the process of his treatment process throughout the whole journey. So the care is coordinated across those disciplines, and there is, this is supported by an interdisciplinary assessment. We are assessing how we are doing, how we are providing care since before the surgery till the rehabilitation and even after that. We have two different standards. The standard blue is tailored to the patient, what the patient needs, and the one in red is tailored to the clinical care of the patient. So by comprehensive care, we develop a treatment plan. The patient, his family, and the caregivers are involved in the whole process. Ideally, this is how everything should be done. There is an interdisciplinary collaboration, but also we involve the patient. We provide him a counseling and psychological support. These people, they go through a lot, so they need counseling and be psychologically supported throughout this process. And if possible, if available, having a peer support program could help a lot that patient. If he speaks with someone who had a similar experience, this could help a lot that patient. And also healthcare providers, especially people involved in rehabilitation, they should provide an education to the amputee on how to prevent falls, but also education on safety and on the caregivers, how to take care of that person through the rehabilitation process. A discharge plan should be made by the medical team, the surgery team involved, but also the rehabilitation team should be involved. And this is done by communication, by communicating between all the stakeholders involved. For kids who underwent amputation and also people who underwent upper limb amputation, it's also good to transfer them, to refer them to specialists, people who have been specialized in pediatric limb loss management or upper limb amputation management. And especially, as I said before, to the clinical care, we should educate the patient on how to take care on the residual limb. We should educate the family caregivers and update them on how to take care of that patient throughout the whole process. And very importantly, the pain should be managed before and even after the surgery. The pain should be monitored throughout the hospital process. And for people with special needs, like older people and some other special population, like people who underwent amputation but involved in higher sports, they should have a comprehensive care tailored to the special needs. Next slide, please. So let me come again on the comprehensive care. Comprehensive care, as I said, the patient is involved in the whole treatment process. Not only the medical team, the rehabilitation team, but at all stages, we should involve the patient and his family and also the person who are taking care of that patient. And if we have community health workers, these are good health workers that can follow up with that person in the community. How is he doing? And act as a link between the patient in the community and the health system, and the health center and the hospital. Next slide, please. And as I said, we should do an assessment of the amputee's needs before doing surgery. We should assess not only the physical condition, like how we used to do, and the pain, but also go beyond that. We assess the psychological status of that patient, his or her frustration, his or her anxiety, their lifestyles, their expectation and goals and future goals. Next slide, please. And as healthcare providers, especially primary care workers, we are called to look beyond the clinical walls. We are called to look beyond what we see, beyond what the patient is presenting. At UGHE, we've been incorporating the social determinants of health concept in our curriculum. So these are the conditions in which we live, we are born, we grow, that have a big impact on our health, but also on a variety of functioning and quality of life outcomes. After assessing the physical status or like the presenting complaint of that patient, go beyond and also his education status. Does he have enough social support? How is his working environment? How is his family income? So we are called to look beyond what we see that the patient is presenting. Next. And however, there are some challenges to providing holistic care. Traditionally, in the medical teaching or medical training, we used to learn mostly about the disease without a focus on the social determinants of health, without a focus on the other factor that can affect the health of that patient. So this can be a big challenge, especially where medical students, nursing students are being taught on just on the disease, on how to deal with the disease without looking beyond that. But also the other challenge is that most of the educators, especially those who are non-medical, they have a limited knowledge on the other factor that can affect the patient life. In the clinical setting, sometimes most of the time there is a workload, there is a shortage of staff. You can find that you have a medical doctor, but you don't have someone, a rehabilitation specialist. And these people with that big workload, they have a large number of patients, and the doctor is left alone to manage that patient with who underwent amputation. They tend to do what they are routinely used to do. They will just treat the pain, provide the necessary medication, and just refer that patient to another rehabilitation center, most of the time in urban area, without following up with that patient. And also our personal trait, especially here I'm talking about doctors, nurses, how we are compassionate to the patient, how we care to our patient. This also has a big impact on how we can give holistic care. And personal experience, if we have someone in our closest relatives who underwent amputation, I'll be more at ease I will be understanding of what that person is going through. And this can help me on how to provide a comprehensive care, focusing mostly on the patient. Next slide. So it's our goal. We are called all the policymakers, the leaders, the healthcare providers, the policymakers. We are called to change how we provide healthcare since the lowest level. So let's revise the education content. Not only we are not supposed to focus on what the patient is complaining about, but let's look beyond that. And modification of the condition at work, especially in the hospital, increase the number of healthcare providers, increase accessibility to the rehabilitation services, especially in the rural area. And also, as healthcare providers, I must emphasize on this, improve our communication skills. How do you give the bad news to someone who's going to undergo amputation? How do you accompany him throughout that process? Let's be sensitive to the amputee's culture and spiritual belief, but also, and importantly, we must recognize and treat each amputee differently individually. Thank you very much.
Thank you, Dr. Masimbi. That was really insightful. Our next speaker is Dr. Cyprien Shirambere. Dr. Shirambere is the director of the oncology program at Partners in Health in Shutimo Buzima, where he coordinates all the operations of the Butaro District Hospital Cancer Center of Excellence and supports all the government efforts to advance cancer care in Rwanda. Dr. Shirambere holds a Master's of Medicine in Pediatrics and Child Health from the University of Rwanda. He also received his oncology experience from Dana-Farber Cancer Institute and Boston Children's Hospital. Please welcome Dr. Cyprien Shirambere.
Thank you very much, Claudine, for the introduction, and many thanks to the organizers for giving me the opportunity to speak today. I want also to thank the previous speakers because they really showed a picture of how we approach the care of the amputees, and they have already highlighted some gaps in the rehabilitation services. So most of my talk today, I will be somehow repeating what other people have said. So as Claudine said, I work for Partners in Health in Rwanda, and I'm leading the oncology program. Since 2012, Partners in Health is working with the Ministry of Health to provide quality and affordable cancer services to Rwandans and other patients from neighboring countries. We provide a wide range of services, including chemotherapy, surgery, radiotherapy referrals, and palliative care. And we do provide some form of rehabilitation, which I will talk the gaps later. Bone and soft tissue sarcomas are not the most prevalent cancers that we see, but we do see some cases of osteosarcoma and other sarcomas. And amputation is a preferred surgical technique because limb sparing surgery is not well established in our country. I was asked to talk about gaps in knowledge among the physicians in Rwanda and to give the experience of our hospital in terms of care provided to amputees. I have to say that I'm not a surgeon by training, so this will be an opinion of a doctor who worked in Rwanda health system, from district hospital to teaching hospital, now to a specialized hospital. So the surgeon here, if I say something that you don't agree with, so that will be an opinion from what we have been seeing in my career. So before talking about gaps, I want to say that Rwanda has done a very good job in training of healthcare providers in various domains, including a good number of general practitioners, specialist doctors, including surgeons, and healthcare technicians, nurses like occupational therapists, physiotherapists, and anesthetist. So this, I think you have done a very good job as the person from the University of Rwanda has said. So when you look at individual level, then all the skills needed in the country to provide good care to amputees is there. But unfortunately, the majority of our hospitals, including the district hospitals, they don't have access to some of those skilled people, mainly due to limited resources in the hospitals and due to competing priorities. So the district hospitals in Rwanda, you will find them really focusing on primary health care, maternal and child health, infectious diseases. So the focus on other, we package them under non-communicable diseases, then it is, there is many things that need to be improved. And unfortunately, amputation is still considered as a simple, if I can say so, procedure, which can also be done by general practitioners who did not get enough training on the techniques of amputation, and they are being done in hospitals where there are not all those resources that are needed for a comprehensive care of amputees. So what you will see, what we see as gaps is that you see some people we not have enough amputation techniques to start with, because some of us then will focus on getting the disease away. So you have something on your leg, I have a margin, a free margin, then I'm happy. But sometimes we don't consider that there is a life after amputation. You see? So if you think carefully to consider that there is life after amputation, then the choice of the amputation site becomes important. The discussion with the patient, the discussion with the other team members about the choice of prosthesis to use, education about life after amputation, the role of the physiotherapy to prepare the patient for the prosthesis then becomes a challenge. So when you don't have all this organized around the patient, then you will see patients struggling after the amputation. Struggling because the amputation was not done appropriately. The physiotherapy was not done earlier enough to make the amputation stamp well enough or well positioned to fit in the prosthesis. Again, the doctor who spoke before me highlighted the lack of communication skills. We have a lot to improve around communication. Communication is very key. We don't take enough time to communicate to our patient, especially these who are going to lose a limb. So someone who is going to lose a limb we should take this as very serious, because there is a whole things that are going in their mind. So it is our role as doctors, because we cannot unfortunately, this is a task that we cannot give to other people. It is us who have a role to talk to them, to work with the psychologists, to talk to them, to prepare them for the life after the amputation. So the hospital where I work, it functions as a district hospital with a specialty of cancer care. And we are lucky to have a general surgeon who performs the amputation. So we are, in terms of the techniques, we think we are good. But in terms of what to offer after that, we are limited to providing them with crunches and some form of physiotherapy. And we have to refer them to the rehabilitation centers, where unfortunately, as far as I know, most of the services they need, like prosthesis, are not yet covered by the community health insurance, which covers over 90% of our people. So what I will recommend is that we should do advocacy to do the decentralization of these rehabilitation services to district level, so that the patient can get the services close to them. I will recommend to organize training workshops. So after we have done with our medical training or the other trainings, so the on job, we should organize workshops as part of the continuous professional education to continue to educate our healthcare providers on rehabilitation services and the interdisciplinary approach to amputees. And we should also advocate for all the insurance to cover this prosthetic product, because they should not be considered as luxury. They should be considered as basic medical commodities as we give other medications. So thank you very much, and I will be happy to get your comments or to answer questions if any. Thank you very much.
Thank you, Dr. Cyprian. That was really insightful. It was nice to learn about what's happening at Butaro District Hospital, what's lacking and what can be improved in support of the amputees. One thing that everyone mentioned is about the need for interdisciplinary approach. I think that's really important in this field, as we just heard from Dr. Cyprian. We end up amputating people, and then we don't have like the physiotherapy care to provide to them, and we may have to refer to them to like rehabilitation centers that might even be so remote. One thing I would also add is that we also need to educate our society, because we need to educate ourselves in general, because the society we live in, as we make the society, so the amputees, we go back in this society, and we end up facing people who may not be familiar with prosthetics, or they are not familiar with seeing a person who has lost a limb, and that sometimes becomes very challenging for the amputee, and it disturbs our mental stability, because that's just stigma, and stigma is something that like affects all of us with physical disabilities in general, because it just takes our amputation and associates it with disgrace or like negativity in general. Like there's a negative attitude around being around amputation, or around like Asimwe pointed out in the previous slide about cosmetics and seeing a person with a prosthetic limb that looks robotic or doesn't match the other leg, and people like start looking at us in different ways. That really affects how we go on through life, and that's something we also need to remember, especially for those who are not in this field, who might not be familiar with what's going on. I would urge you to like continue educating yourself, and also as you go back into your communities, especially for parents, educate your kids about like different kinds of disabilities, so that when they go on the road and they meet someone who is missing an arm, they don't start crying, or like they don't start running away just because they saw someone who is missing a hand, or like who is missing an arm, because that's something that could happen to anyone. And I did talk about in yesterday's session, I brought up the need to incorporate amputees in decisions that pertain to infrastructure. Like if you're going to open a restaurant and you put in a ramp or an elevator, just remember to put the button somewhere where a person who is in a wheelchair can reach, or someone who is wearing a prosthesis, make sure the ramp is not too steep, so that when you're walking, it's not another challenge. So, and then like I would again stress the idea of like establishing more rehabilitation centers, and even like hiring physiotherapists at hospitals, because the physiotherapists, which sometimes are also referred to physical therapists, they are not only needed in rehabilitation centers, they can also be based at a hospital like Butaro District Hospital or King Faisal Hospital. And they can be right there to provide the direct services, because as we know, like rehabilitation, like sports rehabilitation, or like rehabilitation that supports like the occupational therapy of a patient, those things really help us be able to integrate ourselves back into the society after we have gone through the challenge and the trauma of losing a limb. So I would like to invite our speakers back on stage just to for a few questions, please, from our audience and some of my own. Please, for the speakers from this session, can you turn on your videos, please? That would be Dr. Onella Masimbi, Dr. Jean Kagwiza, and Dr. Cyprien Shirambere. Thank you, guys. So now my first question, I would like to ask Dr. Cyprien Shirambere. You talked about the lack of communication, and you also brought back the idea of interdisciplinary approach that is needed to support amputees. So I wanted to ask, how do you think communication can help improve? How do you think communication can help physicians improve in helping like reduce the amputee trauma before and after going through an amputation? Because I just know that as an amputee myself, one of the hardest thing is hearing that you're going to lose a limb. And another even harder thing to process is when you actually lose the limb. And also to follow up with that, what is the hospital currently doing right now? What are the physicians doing right now? Even though there is a lack, there are so many things that are lacking. What have you done in the past to help ease the trauma for the patient? Thank you. I think you're on mute. Doctor.
Sorry, yes. Can you hear me now?
Yeah, now we can hear you. Thank you.
Yeah, sorry. Yeah. Yeah, thank you, Claudine, for the question. I think we should consider communication in this context of preparing a patient to amputation as a formal, don't know if I'm calling it a formal technique to prepare patient to this traumatic event. Because what I always tell to my colleagues or to my trainees is that we should consider a patient as a human being, as a whole, before we see him as a patient. Okay? Because if I see you as a patient, I only look at the tumor you have in your leg and I focus on getting it away. But if I consider you as a human being, then I will consider all the sufferings that you are having. Okay? That you will need to have a life after. You have to be able to walk and to go to school, to go to work. How are you going to do that? Then you need a life without pain. So I need to prepare you, and most importantly, I need to tell you that life can continue to be good. Okay, you can still be a champion. You can still be a doctor. You can still be a beautiful lady actually after the amputation. So, like that component of life is not gone, or life it is not going to be a half life. It's a life that you want. So, as you can understand, we we, the doctors, our strength has not been in that aspect. Our strength has been, we think our strength is in the techniques. I mean, doing surgery and moving to a next patient, you know, and we think that we can delegate this to other people, but if we're not there to coordinate them, you may have a number of psychologists in a hospital. You may have a number of therapy, but if you, the doctor, as the treating doctor, if you are not coordinating all these services around your patient, then it will not happen. Thank you.
Thank you so much, Doctor. I actually remember visiting a patient at your hospital a few months ago, and she had bone cancer in her elbow, I believe. And one of the next step of her chemotherapy was to remove her arm, but she had completely refused to get her amputation. And I came in to talk to her, and I think I remember thinking that the reason she had refused, one, she hadn't seen anyone with the same kind of issue or like had from anyone who had had an amputation. And the people who were serving her didn't really know anything about prosthetics or like what options are there for her after she goes back to the community, because her biggest worry was like, how am I gonna go home to my husband? How am I gonna carry my kid again? How am I gonna go back and work in the field, because she gardened a lot? So yeah, what you are saying really does make sense. So the next question is directed to Dr. Onela Masimbi. You mentioned about the importance of community health workers, and I just wanted to like ask if you can please explain the role of community health workers in general, because there are some people in our audience who may not be familiar with what community health workers do, and if you can tie that back to how it fits into the holistic approach to amputee care. Thank you.
Thank you, Claudine. So in general, in Rwanda, we have over 60,000 community health workers. So people who are not familiar with the Rwandan health system, community health workers, they are people in the community without a medical background, but they have a basic educational background, who act as the linkage between the health system and the people in the community. So those people, they work in the villages, and we have different health program. We have the home-based management of malaria cases in the community, where, for example, they do rapid tests, and where they provide anti-malaria drugs for simple cases and transfer the complicated case to the nearest health center. That's in general what they do. And specifically to amputation care, community health workers, I do think that they can help if we have a community-based rehabilitation process, or if we have another special program that exists in the community, like a discussion or peer support group in the community. Community health workers, they can help follow up amputees in the community, follow up with how they are doing, and if there is any moderate or mild complication, they can just inform the people, the healthcare providers, but also for major complication, that we act as the voice for all those people in the community who can't reach the hospital, and they will be calling for help on their behalf. So in general, they can help follow up amputees and accompany them through their healthcare journey in their local villages. Thank you.
Thank you, Dr. Masimbi. That's a really good point you made, and you reminded us that these community health workers are coming from within the community, and perhaps something that they could consider is thinking of including amputees within the community health workers, so they can like reinforce the rehabilitation idea and the reduction of trauma and integration into society. So thank you. Our next question is for Dr. Jean Kagwiza. So one personal question of mine, you talked about there being trained, I think 53 associate prosthetists and orthotists who were trained at the University of Rwanda. Do you know the employment rate for them, or like if they're all employed? And then one question from the audience was, what is the university planning to do to upgrade the skills of graduates to meet the needs of the community? Is there rehabilitation innovation hubs where rehab professionals can get together with other professionals to provide solutions that fit the needs of the users, of the prosthetics users? Dr. Kawiza, the floor is yours.
Thank you very much, Claudine. Yes, we have trained so far 53 associate prosthetics and orthotics, but unfortunately, they're not all employed. So I think it's only a half, and we continue doing advocacy. What Godfrey said, I think there's now some improvement, because the structure which was out, I think, 2 months ago, the structure from the Minister of Public Labor, we can see now they are included. And what I know, the Minister of Health is really is doing a lot, and it recognizes the importance of that cadre. So I'm hoping that in the future, we are going to have more opportunities, not only in public or in the government centers or hospitals, but also in private. We are also hoping that some of the graduates are going to be able to do innovations and to be entrepreneurs, to create jobs, to create maybe not very big industries, but I'm sure with the knowledge and the skills they have, they are able to have their own centers. So that's what I can say, but we continue supporting them with the continuous development programs, invite them sometimes so that they can increase their skills and maybe not continuing doing routine work as technology advances all the time. So for the rehabilitation hub, I think I really appreciate that comment. It's a comment, it's a question and a comment. I saw it on the chat. I was about to respond. We don't have such hubs, but what I can say, because it was also with the community, it's the hub, rehab hub, but it's also community, how we prepare students to go to the community. What I can say, the community, we have a course of community embedded in each of our curriculum, and it's a course and it's also shared among the rehabilitation students so that they know, they get aware of what are the problems in the community and how they can address those problems, finding solutions based on the knowledge and on the skills they got from the university. But we don't have such hub, and I appreciate. Maybe we can have further discussion about it, because I think it's going to increase the culture or improve the culture of interdisciplinary teamwork within the rehabilitation phase, and also together with the other health professions. So that's what I can say about the hub. I know associations, rehabilitation associations, they have sometimes forums, they create forums where they discuss about their own professions. That's really an individual initiative, but if we put hands together and facing the rehabilitation and maybe invite other professions, I think it's going to be appreciated. Thank you.
Thank you so much. I see Asimwe's hand up. Yes.
Thank you, Claudine. I will just need to add on what Principal has mentioned about the hubs. This is responding to one of the audience, Mrs. Ines, who happens to be my friend also. The hubs, I think, they are going to start when the Center of Excellence starts. There will be innovative ideas brought to the Center of Excellence of Biomedical Engineering through working with engineers, biomedical engineers, and P&O professionals and other rehabilitation professionals. We can mix all those ideas and bring them to the center to come up with one individual product, or one product being for physiotherapy, being for medical imaging or other P&O services. So another thing is for durable contextualized P&O products. I want to respond to this by saying that even if you send me to be trained, when I get back home, I find similar infrastructure. I have the skills, but I have no way to transfer those skills to my fellow colleagues, or I have no way to implement what I studied outside Rwanda, because the infrastructure is not accepting me to do that. The setting of the machines, the equipment, is not accepting me to work effectively or to show what I know about this particular thing. So another thing we have to look at is not only on professionals, we have also to look on the side of the environment we are working in. If the working environment is not favoring us, we will not deliver good services to the end service users. So that should also be thought about. If we are planning to train people, we should think about how also to improve the working environment. If I release people from Rwanda to go to study prosthetics in US, and they study everything which is related to the current technology in the US, but when they come back to Rwanda, they find we are still using the 1995 equipment. So they will not help them. So we should encourage also those people to plan for their respective hospitals or engage different organizations. I know Ines is working for HI. They are doing a lot to improve the quality of service in rehabilitation. They can also think about it in their own way. Thank you.
Thank you, Asimwe. Actually, you just brought out a good point, which I always think about. It's like when you go to study abroad and then you come back and you find that things haven't changed. That's why we need to think innovatively and think of how can we change the systems that are not working. We don't completely have to remove them, but we can improve on them. And I think, as we have seen through this conference, there are a lot of things that we can really improve on. So there's still a lot of questions from our audience, those who are following us on YouTube and those who are following us on Zoom, but unfortunately we can't go through all of them because of the time, but we will be following up later on. So for now, I would like to invite Professor Anthony Bull for the closing remarks.
Thank you, Claudine. This has been such a stimulating and wonderful 2 days. I'd just like to bring you back to a long time ago. I was a new professor at Imperial College when President Kagame visited us in 2009. And since that time, the college has sought to strengthen its links with Rwanda, with the particular view to improving our interinstitutional research and global health collaboration. And this conference is and represents an important step in that process. And we will continue with a particular view to improving health services and systems. The conference had over 400 attendees and covered a whole spectrum of topics around amputation. We started with a national view of disability and amputation in Rwanda, with the excellent keynote provided by the President of the National Council of Persons with Disability. And through the lens of surgeons, rehab specialists, and world-leading experts in prosthetic technologies and man-machine interfaces, and clinical education specialists, we have seen and have been led to understand amputation holistically. And we learned of the processes that must be in place for the betterment of the individual, their immediate communities, and wider society. But we know that conferences like this cannot take place without individuals who put in the hard work to make that happen. And I really want to thank particularly Claudine Humere, who you've just heard from, the partnership coordinator at UGHE, for pulling the team together to make this happen. The Vice Chancellor of the University of Global Health Equity, Professor Agnes Binagwaho, and the Dean of the School of Medicine, Professor Abebe Bekele, have been critical in ensuring this collaboration moves forward. Laura Watton, Nick Carney, Dr. Onela Masimbi, Elise Nzashimi, and Dr. Robert Ajambo, head of the Physiology Department and Chair of Basic Medical Sciences at UGHE, have been instrumental in making sure the conference strategy, erection, communication, and production materials have all been in place. From the University of Rwanda, the Dean of the School of Medicine and Pharmacy, Dr. Jean-Claude Biringiro, and the Principal of the College of Medicine and Health Sciences, Dr. Jean Kazwiza, who you've also just heard from, have generously supported this cross-institution initiative. I also want to thank my own team here at Imperial College, particularly Dave Hetson and Vasya Vadakastani, for the very hard work that they've put in to push this conference forward, to support our collaboration, and for their commitment to the future of this collaboration. Of course, crucially and importantly, this conference was underpinned by the view of the individual. Amputees from Rwanda and beyond, they generously providing their own understanding and viewpoint of amputation as their condition. And we must never forget that amputation is a condition that affects that person and their family and their community. And underneath all that we've discussed, policy, education, technology, it is that person that is affected through no fault of their own. And of course, we are committed to, and we must always strive to ensure that all that can be done to support that individual is done. I thank you all for your commitment to this, and I thank you for your attendance and participation in this event, and I look forward to future interactions with you all. Goodbye.
Thank you, everyone. Have a great rest of your Sunday and have a great week. And thank you so much for joining us.